start our second genitourinary Viva seat. Candidate number 1.
Yes, sir. Good evening, sir.
Are you ready?
Yes, sir, I am ready, sir. Okay, sir. I request the control.
Yes.
Can I start, sir? Yes.
Yes, 60-year-old male patient presented with abdominal mass.
So, I'm presented with CT abdomen and pelvis of a patient, but presented with abdominal pain and abdominal mass, starting with unenhanced CT, axial sections. Sir, I could requested the control.
Here. Yalla, go. Use arrows. You can use arrows. Yes, go on.
Yes, yes.
Excellent.
Thank you. So the abnormality I can see is in the form of a large heterogeneous mass in left renal fossa region, which is predominantly ectophytic. I can see
Yes.
the kidney is displaced by the mass and is part of the kidney is seen anterior medially.
Yes.
The lesion is predominantly in the perinephric location on the left side, and I can see some areas of hypoattenuation, probably representing some collection or necrosis. There is marks prairie lesional fat stranding is also noted with some nodularity. Uh, so
Yes.
there is another hypoattenuating lesion in right kidney as well, which
Yes.
is involving middle polar region of the right kidney. However, there is no definitive hydronephrosis noted in bilateral uh, calyceal system, no
Okay.
definitive lymphadenopathy in non-contrast images, and other organs appear remarkable.
This is a
So I'd like to
contrast. Go.
contrast. So yes, sir. Thank you, sir. So these are the post-contrast images in the corticomedullary phase. So the
Yes.
abnormality, as I had seen in the previous image, there is a large uh, heterogeneous mass in left perinephric location, which is displacing the kidney, and I can see the clear differentiation between the mass and the uh, left kidney. So this lesion is arising from the left perinephric space uh, away from, and
Excellent.
so there is a distinct border between kidney and lesion. So this is not of renal origin. This is in arising in the perinephric space in the retroperitoneum
Excellent.
and heterogeneously enhancing. Another lesion
What
which I
else?
had seen.
What
Uh,
happened here? What happened here?
so there are certain areas of hyperattenuation as well. Could represent some hemorrhagic component.
Are you sure? Look here. Which face this one?
So this is corticomedullary phase, and the lesion is displacing the abdominal fat and is
So this is what is this? This is contrast. So what is
this
this?
is
What
contrast.
is
So
it?
this has heterogeneously enhancing soft tissue, solid
Okay.
component.
Okay. Give me differential diagnosis and the next step. Excellent, doctor.
So as this is arising from the perinephric space of, so I keep the differential of liposarcoma in this particular case because this is a large heterogeneous mass, extrarenal in origin, uh, and another can be a sarcomatous other than liposarcoma, could be another soft tissue sarcoma.
Oh, okay. Why is this lesion not a benign lesion? Why you are talking about malignant lesion?
So the one thing is the size. It is a very
Excellent.
Another thing is the nodularity and the peripheral irregularity, which I can appreciate, and it is causing significant mass effect in the form of displacement of the kidney. And other
Excellent.
thing is significant peri-lesional fat stranding, which is commonly seen in aggressive kind of lesions, either in infections or malignancies.
Excellent, excellent. What else? And what about this solid component?
Yes, heterogeneously enhancing solid component is
This is
also
the
there. We-
most important sign of malignancy, especially
Yes.
see multiple non-uniform solid enhanced component. What is your next step, doctor?
So I would convey the finding to the referring physician, and for the definitive diagnosis, I'll advise for the biopsy of the lesion, either CT guided biopsy or ultrasonographic biopsy, whichever is feasible, and then carry on with the oncology MDT for further management.
Excellent, but one mistake you did before
Yes, sir.
biopsy. Before biopsy, this is a complete soft tissue tumor. Something
Yes, sir.
must be done. Some investigation is a unique or as a specific for soft tissue component or soft tissue tumors must be done before biopsy.
Yes, sir. Yes.
Yeah, what is this? Tell me before biopsy. What should you do? What about MRI?
So whatever I'll do MRI, sir. Yes, sir. Yes. For further
Yes, why? Why
characterization.
MRI? Because MRI will help you too much and will show, يعني will help you for further characterization. Okay?
Yes.
Yeah, see, because if it is liposarcoma, you will see some fat, okay, in MRI,
Yes.
and this is important. Anyway, doctor, you did very, very well. Amazing. Your style is very promising. Are you a John candidate or October candidate, doctor?
So I am June candidate.
Thank you, Doctor Lemish Lemshan. Thank you so much. I
Lamichani.
think
Yes,
thank you,
yes, sir.
doctor. I think this is the
Thank you.
first time for you at our group. You did very, very well. You are amazing. See my colleagues, large retroperitoneal left perirenal mass lesion. Leave the mouse, please. Why this is not a renal? Look at the maximum size. The most of the size of the tumor is centered at within the pre-renal fat. Okay, and just surrounding or partially surrounding or abutting and displacing the left kidney. Second point, there are no close sign of renal tissue. If this of renal origin, you must see renal tissue here, okay, stretched and like a close sign surrounding this tumor. Okay, then he searched for any solid component. Okay, there are a solid component here, okay, and then he put, see here, my colleagues, in more delayed phase, it is يعني more enhanced. See, all these are solid components, more enhanced. So he gave me a logic differential diagnosis, including liposarcoma and the other sarcomas of the retroperitoneal. Thank you, doctor, very much. You did very well. This is left retroperitoneal perirenal liposarcoma. Next candidate.
Thank you, sir.
Yes, sir.
Welcome. This is okay. 1 second. 16-year-old male patient presented with left testicular mass. Go on.
I have been provided with ultrasound grayscale images of an patient who was presented with a testicular mass complaint. Looking at the images, I can see there are multiple hypoechoic area noted within the testicular parenchyma. Um, the testicular parenchyma appears more echogenic. Um,
Oh,
and
why? Why this is not considered a lymph node? Why you are sure this is a testicular mass? يعني I know you see this left testicle, but in the exam it will not be almost demarcated like this. So you must ask the examiner, especially in ultrasound, to see all the areas. See, like this, okay, like this. Why? See, this is the right testis, so this is the left testis. Okay, my colleagues. In ultrasound images, you must scroll all the images first because I think most of the examiner will not show you this writing or this labeling. Okay, doctor?
Yes, sir.
Okay. Yeah. Start, start again.
Okay, I have been provided with the ultrasound images of when a patient. Uh, I'm looking through the whole set of the images. Here I can see there are
Yes.
uh, the right testis appears smaller in size and
Okay.
appears irregular. And there is a mass lesion noted, multiple heterogeneous hypoechoic area noted within the left testes. Oh, so
Okay.
I am concerned for some mass lesion within the left testicles. I would like to see the Doppler image to see if there is any flow in the left test. There is minimal flow is noted within the left testicular. So these hypoechoic area can be a testicular abscess or can be due to some malignancy like uh, due to germ cell tumor. So further investigation would be required for this, like an MRI pelvis to see the malignant characteristic feature. Otherwise, if patient have a history of fever, then these can be multiple abscesses, or otherwise, this can be some malignant tumor within it.
Okay, doctor, before you give a diagnosis of abscess, could you ask you do want to ask me about any history?
Yes, sir. If patient have a history of fever or raised
No,
inflammatory marker, then
no, there is the inflammatory mark.
okay. Um, if a
So
patient have a history of
what else?
uh, raised hormonal level like alpha fetoprotein or beta HC.
Yes, elevated. So what's your differential diagnosis?
Yes, so then this is likely concerning for a germ cell tumor. So I will immediately convey my finding to the referee physician and will arrange a MRI of this patient and also look for any lymphadenopathy, retroperitoneal lymphadenopathy, and will convey my finding to the referee physician, refer this patient to the urogenital. I have been provided with sagittal MRI images of an pelvic region. These
Yes.
are T2 images. Here I can see that there is there is a heterogeneous mass lesion noted within the right testicles. It is of heterogeneous with internal hyper and hyperintense area and some solid component. The solid component show enhancement. Um, uh,
One minute. Some solid component or mainly solid with central necrosis.
yes, there is central necrosis and some solid component periphery, which show significant
This is
enhancement.
almost solid mass, almost solid. And there are central moderate cystic changes. Mainly, see, the mass is almost solid, and there are central moderate necrosis. Okay, go on. What's your differential diagnosis, doctor?
Uh, as patient have raised a hormone level, so this is a likely a germ cell tumor, like um,
Mm. Yes.
there are different variants of this, like a Yorkshire tumor, endodermal sinus tumor. So I'm not exactly sure about what it could be. Uh, other
Could this be a seminoma?
Seminoma not, as it is not as well defined and there are heterogeneous area within it. Uh, so less likely.
Okay. And what about the patient age? Is this the age 16 years old? Is this the age of seminoma or not?
No, this is not the age of seminoma.
So this is at first, this is non-seminomatous testicular tumor. Like you said, including non-seminomatous testicular tumor, including germ cell Euxac tumor and other differential diagnosis. You did very, very well, doctor. Thank you so much, my colleagues. See, the history is very important. 16 years old with mass. So it is not an abscess. So it is not a seminoma. From the history, you exclude two important confusing pathology. And then she go through the examination. She find a mass with moderate to market cystic changes, or you can consider this as a mixed cystic solid mass. Anyway, you can tell the examiner this is a non-seminomatous, at least non-seminomatous. Okay, and this is
Yes.
not looks like teratoma. Okay, so we are dealing with other possibilities like Yoxac tumor and the other list of differential diagnosis. Thank you, doctor, so much. See also here, we must rule out lymph node, any lymph node. Okay, especially here. I think there are multiple, at least left inguinal lymph node. This is very important. And para-aortic lymph node. Okay, but this is a low pelvic examination. The aorta is not visible. But at least we picked, see, we picked up left inguinal lymph nodes, and this is will change the staging of the tumor. Further CT staging, including CT chest, cannonball metastasis. I know cannonball metastasis is common in seminoma. Anyway, but this Yuxac tumor may cause a chest metastasis, lung metastasis. Thank you so much. Next candidate.
Good evening, sir.
Hello.
Yes, sir.
This
Good evening.
patient has a tender and painful pelvis and dysuria.
I've been provided with contrast enhanced CT abdomen and pelvis images of a patient who has presented with dysuria and tender pelvis. On the initial examination, I could see that the there is perinephric fat stranding involving the left kidney.
Okay.
There is also evidence of periureteric fat standing noted on the left side. The left ureteric wall appears slightly thickened and shows heterogeneous enhancement. It appears dilated.
Can you ask for a control, doctor, or you can't?
Yes, yes, I'll do that.
Yes, please. It's better.
I have requested
Go
so.
on.
Yes, sir.
Yes, go on.
There is evidence of a heterogeneously enhancing multiloculated cystic area noted in the region of pelvis. In the region of prostate, I'm sorry, in the region of prostate. It
Yes.
is also extending into the bilateral seminal vesicles.
Yes.
The urinary bladder appears thickened and irregular along its base. Uh, I'm looking for any enlarged lymph nodes. There are a few enlarged lymph nodes seen in the bilateral common iliac vessel region.
Okay.
Hello.
What else?
There is no evidence of any obvious fluid in the pelvis. I'll just take a moment to look at the other organs. These were my main findings. To look at the other organs, there is actually some perinephric fat stranding also seen in the left kidney. Sorry,
Okay.
right kidney. Um the liver appears
Give
normal.
me give me your differential, please.
Based on these findings, my principal diagnosis would be that of an infective etiology involving the prostate, uh, with extension into the urinary bladder, as well as uh, involving bilateral kidneys. So it is prostatitis with cystitis with bilateral pyelonephritis.
What is the name of the infectious process here? What is the name?
It's abscess, sir.
Excellent. Complicated
Uh,
by?
uh, Complicated by a rupture into the seminal vesicles.
Yes. And what about the left kidney? Tell me the most important. The most
So
important.
there's also
Mhm.
pyelonephritis involving the left kidney.
Excellent. And what is
Uh,
this? Hydrouretro
Pyelonephritis.
nephrosis. Oh, yeah. Tell me about the management. Next step.
I would like to inform these findings to the referring physician. Also request for further urine routine microscopy evaluation. The patient will also require further evaluation with an MRI prostate to look for the
This is MRI. See, this is, I think, T2
okay.
diffusion. This is the diffusion. Go on.
I've been provided with
This is-
MRI images of the same patient. On this images, I can see that there is diffusion restriction, the region of the abscess involving the prostate and the seminal vesicles. Uh,
Yes.
I will take a moment to look for any lymph nodes if there are visualized on the diffusion weighted images. Uh, so my findings are confirmed on an MRI of the principal diagnosis of an abscess in the prostate and the seminal vesicles complicated by cystitis and left pyeloureteronephritis. I would like
There
to
are
refer this
one.
patient.
Yes. Oh, tell me.
I would like to refer this patient to the urgently refer this patient to the uh, urophysician, as this patient will require intravenous antibiotics.
Only intravenous
And
antibiotic only.
also the patient will require drainage of the prostatic abscess.
Need what?
Drainage of the prostatic abscess.
Okay, thank you, doctor, so much. It is very nice case. Look, my colleagues, this is a diffusion. Okay, this is the prostate. This is the abscess. Okay, this is another abscess here. And then this is the seminal vesicles. Okay, market restriction. If we compare with the EDC, you will show low EDC values. And as he said here, this is a very good case scenario. Very good case scenario. See here, all of us will concentrate here, but look here, there another disaster here. Left dilated ureter and the sick enhanced, surrounded by smudged periureteric fat and complicated by left hydronephrosis and pyelonephritis. Okay, my colleagues, thank you, doctor, so much. Besides
Thank you,
that,
sir.
there are two gallstones at least. Okay,
Yes,
gallbladder
sir.
stones, and there are some focal nephritis here, but the most important at the left side. Okay, thank you, doctor,
Yes,
so much. We
yes, sir.
must exclude in all abscesses a biogenic liver or spleen microabscesses. Okay, this is very important. Thank you so much. I
Thank you.
know, I know the prostate is drained by a non-mesenteric veins, but at least maybe the infection, maybe the infection is spread from the ureter or the kidney to any of the bowel or to the nearby mesenteric veins and causing metastatic microabscesses to the liver or the spleen. Thank you so much. Next candidate.
Good evening, sir.
Good evening. 60-year-old female patient presented with incidental finding.
Okay.
Go on.
I'm presented with CT axial images, non-contrast images of a patient, 60 years old, who presented with an incidental lesion involving the left adrenal and upper pole of left kidney.
Mm-hmm.
I would scroll through the entire extent of the images before I start to
Go
comment.
on. Go on.
Okay. On scrolling down, I could see uh, a isodense lesion involving
Okay.
the anterior anteromedial cortex of left kidney in the interpolar region.
Okay.
I cannot appreciate any fat density or calcification within the lesion. The
Okay.
renal size appears to be preserved. Uh, I'm going superiorly to see the adrenal gland. Adrenal glands show normal morphology bilaterally. I couldn't appreciate any focal lesion. There was a small retrocrural lymph node. Apart from that,
Okay.
I could see a soft tissue density lesion along the left renal vein, which is separate from
Mm-hmm.
the left kidney. In my routine practice, I would see a contrast weighted images to look for to characterize this further. Before that, I would scroll to the pelvis. Okay, it is okay. I think it
Do you
is
need any sequence,
not.
doctor? You take to يعني more than enough in this non-contrast. Do you need any other phase?
Yes, sir. I would like to see the arterial phase, the
Okay.
corticomedullary
This is
phase.
arterial phase. This is arterial phase.
Okay.
Go.
Scrolling through the images again, uh, I am seeing for any uh, enhancement within the lesion. Uh, the lesion which was seen previously shows predominantly peripheral enhancement with irregular internal septations. This would be approximately 2 or 3 centimeter in size. I am seeing
What
for the
else?
left.
What else? What
Uh,
else?
Apart from that, there is uh, a necrotic lymph node anterior to the left kidney. I will see the rest of the organs and para-aortic region. Uh,
Okay.
Left renal veins are patent, without any renal vein thrombosis. Um,
Okay.
um, there is an
Conclude.
intrauterine device.
Yes, conclude.
To conclude, in the lesion incidentally detected in the left kidney appears to be a hyper-enhancing lesion, uh,
Yeah.
which is concerning for renal cell carcinoma with
Okay.
enlarged lymph nodes as well. So,
Please
since
down. Please down. Ah.
yes,
Give me a differential diagnosis for this. What
my
what are the
and
lymph nodes?
another differential would be that of a complex type 3 Bosniak cyst, uh, and
You sure?
um,
Are you sure? What else? See, doctor, this is related to which anatomical location? See, this lesion related to the vessels
yes,
and
sir.
going to the hilum of the kidney. What is the name of this collection? Nerve, sorry, artery, vein, and something else going to a hilum.
The pelvic calcium system, sir. ureter.
No, no, no. See, what is accompanying a vein and artery when going to the renal hilum? Nerve,
Okay.
neurovascular
Okay.
bundle. This what?
Okay.
So give me another differential diagnosis here.
Uh, Nerve sheath tumor.
Okay, thank you so
Uh,
much. You are right. Thank you, doctor. This
Thank you,
is
sir.
my colleagues at pathology. This is a schwannoma. Why? See, completely abutting the vessels here, and benign looking. Second, this is renal cell carcinoma. Okay, no liver or spleen metastasis. And you didn't ask me, doctor. I wanted to change it lung window to rule out
Yes, sir.
lung
Lung metastasis.
metastasis. Thank you, doctor. So much you did very well.
Thank you, sir.
Welcome. Next candidate.
Yeah. Yes, sir. Good evening, sir. Candidate 6 here.
Yes, request control.
Yes. Hmm. Yeah, I've requested the control, sir.
60-year-old female patient complaining of pelvic
Hmm.
pain.
Okay. Oh, okay. I've been provided with CT scan axial sections of the abdomen in portal venous phase. I'm scrolling. I started from the arrow. Sorry.
No, 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 no. Leave
I
the
put the
mouse.
arrows in.
No, no. 1 second. 1 second. 1 second. 17.
Yes.
Okay.
Okay.
20-year-old
Sir.
female patient presented with pelvic pain.
Okay.
Go on.
Sir, I will try with the mouse only. So.
Okay, I will scroll for you.
No,
Leave the mouse.
it's not moving, sir. Yeah, yes, sir. It's not moving. Yeah. Okay. So, uh, okay. In this city, I noticed that there is a heterogeneous lesion area is noted in the pelvic region.
Okay, leave the
Uh,
mouse. Leave the
yeah,
mouse.
yes, sir.
Okay.
I've left the mouse. Hmm.
Okay. So,
Okay. Yeah. Yes, sir. Having the look again. So scrolling from craniocaudally till now. Yeah. So in the pelvic region, I see a lobulated heterogeneous lesion with a fluid, which is predominantly fluid containing and tubular in nature, with giving a coiled tubular appearance. So I am thinking in line of this being a tubal inflammation like hydrosalpinx. Adjacent
mm,
also free fluid is noted adjacent to the lesion. I'm now looking for the ovaries. Sir, can you little scroll? I'm trying to locate the ovaries. The uterus is looks normal with a copper T device in situ. This tubular structure, ovaries. I'm trying to locate for the ovaries. Right here. In this coronal view, the tubular. Right, right side ovary is apparent. Left side ovary, I am not able to delineate. So with this heterogeneous lesion, which is peripherally enhancing and fluid attenuating in the center and large in the left side, I am thinking of a tubo-ovarian abscess with associated with hydrosalpinx or pyosalpinx. In my routine practice, I will measure the HU of the contents, especially of the tubal contents, to know the character of the fluid. Adjacent
okay, what's your
adjacent fluid is also noted in the pelvis. Yeah.
okay, what's
Yes,
your
sir.
management? What's your
Yes, sir.
management?
So, yes, sir. So, for this is an emergency condition and so needs an urgent attention. So, I will inform the referring physician arrange for an urgent gynecological referral. Also, by the time I will correlate with the lab parameters for the deranged inflammatory markers. So, for gynecological referral for further evaluation, further management, and maybe surgical intervention as necessary.
And what about intervention radiology? You are in
Yes, sir.
radiology,
Yes,
so
sir.
much
So
as
for
possible.
for the this being an abscess, so I'll also discuss with the IR team regarding the drainage of the pus in this case.
Thank you, doctor,
Yes.
so much. This is a
Yeah.
case of
Yeah. Yeah. Thank
pelvic
you, sir.
inflammatory disease complicated by tubo-ovarian abscess. This is a
Okay.
tubo-ovarian abscess, or even it is surgically, if they discover this is a pyosalpinx,
Mm.
the same
Mm.
surgical, okay? Because really
Okay.
it is a convoluted, these cystic structures are convoluted and
Mm.
interconnected, see, to a little
Yes.
bit connection. Thank you, doctor,
Mm.
so much.
Yeah.
And it
Yeah.
is
Thank you, sir. Mm. Mm.
bilateral, mainly left-sided. Thank
Oh,
you.
okay.
Next candidate.
Hi there, sir. Hi. I'm requesting
Hi.
control.
No need. No need.
Okay.
No need. See, this patient has a history of testicular trauma.
Okay. I'm presented with ultrasound sequences and a patient who's presented with testicular trauma. I'm just taking a moment to look through the images. I can see
This
that there
is the,
is no.
this is the right. Okay.
Okay. So I'm focusing
This is
mainly
the
on
left.
the right
This
side.
is the right. Okay.
Okay.
Hmm.
Okay.
What happened?
So yeah. So I can see that on the right side that there is lack of color flow, and there
Okay.
is also hypoechoic widespread areas seen with
Okay.
areas of low echogenicity. I am just trying to assess the tunica albuginea. I
Okay.
can see it is
What happened
intact.
for the tunica? Yes. What
It
happened?
appears it appears intact. There does not seem to be any breach of the tunica
Are you
albuginea.
one minute? This is the most important thing in this exam. Are you sure tunica are intact? Tunica
Is that,
here are
yeah,
intact.
there is no.
Compare,
So
see, 1 second, 1 second. Compare the tunica here, very clear, very sharp. Compare here, see, down, depression, up, down. So tell me your final decision about the
so
tunica.
the tunica are not intact. So this would be in keeping with testicular hemorrhage with fractured. I'm
Yes,
just looking at the rest of the.
what happened?
There is lack of color flow in the right
Yes, okay,
testicle.
there are lag and there are irregularity of tunica. So what's your diagnosis till now? And the history of
Um,
trauma.
yeah,
So
so the testicular fracture.
not fracture.
Sorry,
Fracture, see,
testicular.
doctor. Fractures
Yeah.
means that tunica is intact. Something more severe than fracture.
Would
Something
it be
happened here
testicular
and release some material here. So it is
rupture?
okay. And after 2 weeks, this patient has 2 weeks of trauma. This cribriform septation occurred. And
Hmm.
what happened? This patient
So
neglected
I
rupture
see.
testes after 2 weeks. What happened here?
So after the rupture, there may have been auto destruction of the testis itself with cystic change present 2 weeks
If
following.
I told you patient has markedly swollen scrotum and fever of a neglected rupture testis, so what is this
Testicular infection. I
infection? Which type of infection? Marked
or, or,
septation.
mm,
Hmm.
or kite, um, Oh, I was going to say testicular orchitis, but I'm not sure now.
Something more than orchitis.
Um,
Biogenic infection.
pyogenic
Okay.
infection.
Yes.
Mhm.
Okay. Again, what happened here? There are a rupture, testicular rupture, and then something released from the testis here inside the scrotum, and it is neglected. Upon it, infection and the pus formed. This is a biocell. Thank you, doctor, so much. This is a testicular rupture plus biocell. Next. So it is very important in any trauma case to check the tunica. Any lesion or any hypoechogenicity within the testis with intact tunica equal fracture. Okay, and this is treated conservatively. But if the tunica is injured, this is a rupture, and an emergency or an urgent orchidectomy must be done. Why? Because the release of the content of the testis, including sperms to the circulation, will create an antibodies against the sperms. This is very dangerous. Thank you, doctor, so much. Next candidate. Next candidate. Hi. 30-year-old female patient with chronic lower abdominal dull pain. Request control.
Yes, sir, I'm requesting control. Sir, I requested.
One second. I will start from the beginning. Yeah, go.
Okay, so should I start?
Yeah,
Okay,
start.
this is CT abdomen, contrast enhanced axial section with oral contrast in a 30 years old
Yes.
female. In the
Yes.
kidneys are in the corticomedullary phase. I will take a moment to go through all the images. So in this current study, I've found that in this female patient, uterus is a bit bulky. There are prominent parametrial uterine veins. There is
Excellent.
endometrial fluid. There are
Try,
prominent
doctor,
endometrial.
my advice for you, try to trace the cause of this congestion.
Okay, sir. So as I move further upwards, I'm trying to look in the region of, sir, I'm moving, yes, up. The ureters are normally traced. There is, this is IVC. I'm interior to kidney. There is,
Look here, stop. What happened? What happened here?
so there's a heterogeneous dense, hypodense area seen interior to the left
Don't worry
kidney.
about it. Don't worry about
Sir,
it.
okay.
The key in this, no. Go up. The code in the stop. What happened here?
So this is, so I think there's anomaly of some vein. Yes, this is IPC, this is renal vein. One of the thing is that it is passing abnormally between the SMA and aorta. So
Okay.
it is
What
nutcracker.
is the name?
There's,
What is the, yeah, tell me the diagnosis.
so this is nutcracker syndrome, in
Excellent.
which there is
Excellent. Excellent. Not trigger syndrome result in C, congestion. This congestion occurred due to one of or the left-sided genital vein or ovarian Go up to the left renal vein. See, this one. To the left
Yes,
renal
sir.
vein. And the left renal vein here is compressed, markedly compressed. So the proximal part is under high pressure. So, see, this is a venous hypertension. If you trace down, see, this one. Compare with this side. Compare here. See. Go down. This one.
Left ovarian vein is dilated throughout.
Then here, there are a congestion. Thank you, doctor, so much. So, my colleagues, this is a fantastic case of double film side, double film edge. The first pathology nearly in the last lower slice. The cause nearly in the most upper. See, most upper slice. Fantastic, brilliant exam. This one. And very easy. So, my advice for all of you, you should track the CT or the MRI sequences from the top till the bottom. Very critical. This case, you must smudge completely this easy case. If you follow the proper technique, thank you so much. Next candidate.
Assalamu alaikum, sir.
Plan.
Yes, sir.
This patient has abdominal pain, and this is an
Okay, sir.
ultrasound.
Okay, sir. This is a female patient.
One second.
Okay, sir.
Male patient with abdominal pain and hematuria.
Hematuria. Okay, sir. Sir, I'm provided with ultrasound images, transverse image. Sir, which region they are covering this on ultrasound?
If you don't know the region, what will you do? Describe. Describe. What are you
Okay,
saying?
sir.
What is
Okay, sir. So this is a well-defined cystic lesion identified, which shows a well-defined regular margin and with internal echogenic component that is shown no vascularity. It has predominantly cystic spaces and some echogenic non-vascular solid component as well. I also want to see other images. So this on these appearances is more likely seems to be an abscess or an infected collection.
Okay.
As
What will you do next?
Sir, I will declinate it. Its position it's by 9 centimeter. Okay, sir. So
Okay,
sir,
what
it's not
will you next?
So first I will to locate where the lesion is. Second, I will see its compressive effect over the adjacent structure. It may cause
Okay, doctor,
complication like hydronephrosis.
what's
Yes,
your next
and then,
step?
so next step should be I should advise the intervention radiology to aspirate it and to check the content of the lesion. But I also want to see the complication it may
Doctor,
complicate other.
one second. Like this, you will irritate the examiner to ask you a very difficult question. In your report, which area you will mention for the intervention radiology to drain? What is the name of this area?
Yes, sir. Sir, I also want to delineate it.
Either you should ask the examiner, I want the rest of the examination, or I will do CT of this abdomen or whole abdomen and the pelvis.
Okay, sir.
Okay. Yeah.
Sir, I want to take control.
Yes, please. Request control.
Okay. Requested.
Go.
Okay, sir. Yes, sir. I'm provided with the CT scan abdomen with contrast images. I'm scrolling from top to bottom, from bottom to top. First, I want to check all images.
Mhm.
Okay, sir. The lower section, upper section of abdomen appears unremarkable. Both kidneys appears to be fine, a small cyst in the right kidney. Both ureters are delineated.
Mhm.
So at the lower section, at the level of the urinary bladder, I can appreciate there is a large. It's not. Okay, sir. So there is a well-defined large cystic lesion identified, which is anterior to the urinary bladder. It shows some calcific
Okay.
component and few septation as well. It is
Yes.
causing compressing effect
Leave
over
the
the
mouse.
adjacent structure, but
Leave.
not infiltration. Yes, sir.
1 second. Leave the mouse. Is
Yes, sir.
this
Yes, sir.
only that urinary bladder? See?
No, sir, it's compressing, but it's not originating from the urinary bladder because fat planes are quite intact with the urinary bladder.
Okay. What happened again?
Mm.
Hello?
So at the dome,
What's your differential diagnosis?
sir, is a large solid cystic lesion anterior to the urinary bladder. It shows calcification as well. Sir, it may represent a germ cell tumor because it shares
What else?
calcification, cystic component, and debris. And
What else?
sir, it may represent a large lymph node, but it's single node. It's not other lesion is there.
What else?
Uh,
Look
sir,
here.
or may it represent a large divert? Yes.
Yes, huh? Go on.
So it may yes, it may represent a large diverticulum which arising from the bladder.
Okay, two.
But sir, I don't find any communication.
See,
Yes,
see,
sir.
see. Doctor, you are not very far. What is the structure?
Yes, sir.
What is the structure from the superior aspect of the bladder extend
Yes, sir.
superiorly? What is the name of the
Okay,
structure
sir.
here?
Sir, it's
What?
a urogenital sign. Yes, sir. Urogenital. It's a sinus, sir, which is communicating with the umbilicus up to the urinary
Okay,
bladder.
what is the name of this is the structure that connected the umbilicus with the bladder?
Sir, it's a no, not remember. Sir, it's
The
urombilical
arachis.
sinus. It yes,
No.
urachus.
The
Yes, sir.
arachis. The arachis. Okay.
Yes,
And
sir.
what
Yes,
happened
sir.
here? This is just a sinus or something more than a sinus.
No, sir. It
Look,
has a solid component. Yes, sir.
so
So, sir, it may progress into adenocarcinoma because it's more common in urachus sinus. There's chances of adenocarcinoma.
okay, give me your final diagnosis. What's your final diagnosis?
Yes, sir, it's a urachus sinus, not diabetic urachus sinus, but it's not communicating with the sinus. Sir, it's a complicated urachus sinus within solid
Not
component and
sinus, doctor.
calcium.
Doctor, not sinus. Why? This is not open, has no opening,
Not
either superior
open.
or
Yes,
inferior.
sir.
This is
Diverticulum.
arachis.
Yes, sir.
Yes, yes,
Yes,
yes.
sir.
This is
Urachus.
arachis and
It's
has
urachus
solid compound.
diverticulum
No.
component.
See, see, see. Diverticulum, this is means it must communicated with the bladder. Sinus,
Yes,
it
sir.
must has an opening with the umbilicus. This is arachis,
Mm-hmm.
has solid component.
Yes.
So this is
Mm.
adenocarcinoma of the arachis. Simply,
Urachus.
very
Okay,
simple.
sir.
Okay?
Okay, sir.
Thank you, doctor, so
Okay, sir.
much. See,
Thank you,
see this
sir.
septi? See. I have a
Mm.
question, doctor. Someone
Yes,
may
sir.
protest and they said this is just enhanced septi. What
Yes, sir.
is the maximum size or thickness for a benign septum?
So it's less than 3 mm. If it is more than 3 millimeter, it's not benign
No,
septic.
less than 2 mm. And this next point
3
should not
mm.
be nodular like this.
Yes,
Okay.
sir. Mhm.
Thank you,
Yes,
doctor,
sir.
so much. Next
Okay.
candidate. Hello?
Hello.
Hello?
Hello, Assalamu alaikum, sir.
Yo, Salim. Raise your voice, please, doctor,
Okay.
and request control. 25-year-old female patient presented with recurrent left-sided pain.
Left-sided pain. Okay.
Left-sided Leon pain. Go on. See, you should start with
I am
this.
provided with the.
1 second.
Okay, sir.
Okay, go on.
Okay, I'm provided with the multi-planar, multi-sequential MRI of the abdomen, pelvis for striking abnormality. In this MRI, I can see that there is significant mild to moderate hydrouterine nephrosis noted on the left side. Sir, it is not okay now. Okay. There is also a significant enhancement of the urothelium is noted. There is enhancement along the retroconal fascia and lateral the retroconal fascia is also noted. I would like to so the image is jumping. Can you please scroll for me? Okay. And in this images, I can see that there is some debrinous material in, especially in the lower pole and middle pole of the left kidney. Ureter is also significantly thick-walled and is showing enhancement. I would like to trace it to the up till the vesico-ureteric junction, for which, yes, I would like to see it on axial images. And now I'm looking at the axial images. I can see that the same findings are redemonstrated, and I can see that there are fluid levels in the kidney as well. But I would like to see it on other sequences, and also want to do ultrasound of the kidney to see whether it's air or it's any other fluid content. I would, yes, there is thickening of the ureter as I go
Doctor,
down.
1 second. One second. Why do you want to do ultrasound? Why?
Sir,
Before if
okay,
you
sir.
revised, if you revised the rest
Okay,
of
sir.
the sequences, you will show something here.
Okay, sir.
Okay. By
Okay,
the
sir.
way, this is a contrast. This,
Okay,
see,
sir.
this is which one? This is supposed to contrast. See,
Okay, sir.
this is T1. Okay. Is this
Okay,
air?
sir.
This
Yes,
is
sir.
just
This
a
is
fluid.
yes, sir.
Fluid.
Yes, sir. This is air. Yes, sir. Air fluid levels are noted in the pelvic radial system, so it is most likely infection, which is leading to emphysematous pyelonephritis with significant fatty strandings in the perirenal area. So this is a medical emergency. I would urgently pick up my call and refer the patient, tell the findings to the referring physician, and refer the patient to urosurgical emergency for management of the patient, as it has got a mortality rate of up to 80%. And I can see that there is also a tract which is located posterior, which is likely indicating that the abscess has ruptured into the soft tissues, and it has managed to pass up till the soft tissues of the posterior side or the back of the body as well.
Okay, tell the skin. So this is a
Nephrocutaneous fistula.
Excellent. Excellent. Give me your final diagnosis, please.
So it's a significant infection with the emphysematous pyelonephritis with rupture of the abscess causing nephrocutaneous fistula.
Thank you, doctor, so much. But tell me, what is the treatment of this case?
Sir, surgical. It is surgical referral case because it has got high mortality, and urgent surgical nephrectomy has to be performed. Otherwise,
Thank you
yes, sir.
yes,
Thank you, sir.
so much. It was a case of Pyelonephrosis complicated. Why? Nephrocutaneous fistula. Next,
Hello.
could you request control, please?
Sorry, I can't request control because it's
Okay.
it's not a desktop.
This patient presented with this area.
Okay, so this is T2 sagittal sections, MRI sections of the pelvis. You can
Yes.
see that there is bladder apex and anterior and superior wall irregular mural thickening. And this is the T1 axial sections showing the same finding. There's a thickening of the bladder wall.
Okay.
I'm trying to look at adjacent lymph nodes. There's no sizable lymph nodes.
What happened here?
This
is the bladder thickness. And what else?
The ureter appears mildly dilated left ureter. This is the prostate.
Yes, what happened?
There are some foci, hyper-intense foci in the peripheral zone. Some
Are you sure?
central hypo-intense.
Yes.
Hypo-intensity in the transition zone. Sorry, in
Central
transition
only.
zone.
Look at the peripheral zone, please. What happened for the peripheral zone?
It shows some hyper-intense signal, foci.
Yes. What's your diagnosis?
Can you please scroll for me? Maybe I can.
Which sequence is this one? T1 or T2?
This is T2.
Okay. In prostate, the peripheral zone normally high or low in T2?
Low.
Normally.
It's not high. It's not high, but it's intermediate.
No, it is high. It is bright.
High. Okay.
In T2.
Okay.
So this is normal
Okay.
or
So
abnormal?
So this is normal, but there is
what happened here,
focus
doctor?
of hypointensity. Yeah. This
Yes.
there is.
So what's your diagnosis for this hypointensity? See the prostate? This is diffusion.
Yeah.
What happened here? Here.
There is
Something. And
yeah.
the result is elevated PSA.
Okay, so there are some foci of restricted diffusion in the peripheral zone, which warrants, which could be or likely to be prostatic carcinoma.
Excellent.
Or
So
it's Spired's.
Final diagnosis, please. A case of carcinoma
and bladder. I'm not sure. Is this a concomitant diagnosis, or is there some spread of the?
not spread.
It doesn't seem
Why?
that it's local.
No. See, not spread. Why? The spread from the prostate should first start to the adjacent seminal
to the bladder
vesicle.
base. Yeah. Oh,
no,
yes,
one
yes.
second. 1 second. This is at the 6 from 4 o'clock, 5, 6, 7. Okay, at the posterior part of the prostate. So it must invade first seminal vesicle and ejaculatory duct. Okay, so this is not invasion or a metastasis from the prostate. This is asynchronous urinary bladder cancer
Synchronous.
and
Okay.
prostatic cancer. What's your next
Okay.
step, doctor?
So I will alert the physician about the findings,
Before
and I will
alerting,
recommend.
what
request
radiologist? Yes,
request correlation with the PSA, and I
yes.
will
What
check if
else?
there is any previous imaging.
Okay. What investigation would you ask for this patient of the cancer?
Cystoscopy and a biopsy for the bladder cancer, and
What else?
transrectal
Metastatic workup.
ultra.
As
Yes,
a
and
metastatic workup, what would you do?
we can request chest, abdomen, pelvis staging CT,
Okay.
and a
If
bone
you
scan for the prostatic for metastatic
excellent, excellent.
staging.
What is the nature of the prostatic metastasis within the bone scan? What is its
Sclerotic
appearance?
metastasis. Sclerotic
Okay.
metastasis.
If we will do a PET CT, what is the name of the tracer for for detecting prostatic mets?
MDP.
Gallium plasma.
Gallium.
Gallium,
Okay.
gallium plasma. And for recurrence, choline. Okay, two different tracer are used in PET CT for prostate. For prostatic metastasis, detection of the metastasis, gallium plasma. Okay, and for prostatic recurrence, choline. I don't, I forget the full name, but choline plus something else. Anyway, thank you, doctor. Take care, my colleague from synchronous tumors. Thank you, doctor, so much.
Thank you.
Next
Thank you.
candidate.
Yes, sir.
Dr. Amiga, I think this is the last candidate.
Sir, I think
Yeah.
there was one backup candidate as well.
Rami, since one candidate was not there, we can take Dr. Amer also if he's available. We have one backup candidate.
Okay. Yeah, doctor, go on.
Okay, so I'm provided with retrograde urethrogram images, and I could appreciate that contrast is given through the with catheter in the bulbar urethra, specifying the prostatic and membranous urethra. However, there appears to be leakage of contrast noted in the perineum. However, there is some of the contrast is passing into the bladder as well. So I'm thinking of incomplete transaction of the urethra, and I would like to know if of any possible history on the these images. I think it's below the leakage is below the membranous urethra, or maybe at the junction of membranous and the bulbar urethra.
Doctor,
And
doctor,
yes,
no
sir.
history of no
No
history of
history.
trauma. Yes,
No history of trauma, sir. Any history of instrumentation?
nothing. What happened here, doctor? What happened
Sir,
here?
sir,
Where is the contrast going?
sir, I
And
think
the
it's
next question you should ask yourself, is the urethra is intact or not? Hmm.
sir, the urethra is intact anteriorly, but posteriorly I could see the contrast passing into. I think it's a vast difference. I'm not sure.
Okay, where is the contrast
There's,
go? See. This is a whole
yes,
length
sir.
right here. Some narrowing occur here. And then the doctor or the technician give more contrast. Where this contrast go?
Oh, okay, sir. I think there is an additional opening.
Again, please.
Epispadies through which contrast
Again,
is.
what happened?
Epispadies. So I think there is some additional opening on the ventral surface of the penis through which contrast is given.
Wait,
Epispadies.
no, I didn't listen you well. Where is the contrast go?
Sir, I think
Hello?
it's going in some vessels, maybe.
Yes,
Hello, can
okay,
you hear me,
excellent.
sir?
What is the name of this process?
So not sure.
When you inject the contrast under pressure, what will happen? In
Intravasation contrast, intravasation within the vessels.
excellent. Okay. Why the operator inject the contrast under pressure? Why? What happened here? There
So there may be some structuring due to increased pressure. The contrast intervasited.
Okay, where is this
Fracturing.
structure? In which
Sir,
part
this
of
is
the urethra?
membranous urethra.
No, see. The membranous is much posterior, but see, the
Okay.
structure start from here,
Okay.
till here. So all this
Bulbar.
part, what is the name of this part? If I told you this, hmm?
Bulbar urethra.
Valvular urethra. Thank you, doctor, so
Yes, sir.
much. This is, see my colleagues, this is a prostatic urethra. And till here, till the lower part of the bone of the pelvis, and you can consider this is till here, the
Okay, sir.
membranous urethra. Okay, from here, posterior, this is a benign. So this intermediate signal from the bone till here is the bulbar. Okay, so this is a bulbar urethral structure. The operator do a lot of pressure, when he was injecting the contrast. So the contrast to go intravenous. So this is intravasation of the contrast. Thank you, doctor, so much. Dr. Hello? Hello?
Yeah, hello, Dr. Rami. I am just looking for the backup candidates, Dr. Omer, Dr. Bushra.
Hello. Hello, I'm here.
Yeah, Dr. Bushra, are you
Yes,
there?
Okay.
yes, Dr. Poshra,
Yeah.
what's
She is
your
there.
diagnosis? Tell me,
So this
spot diagnosis.
okay. This is likely bladder outlet obstruction. The cystogram showing thick walled urinary bladder showing multiple trabeculations and diverticulae. I can see Foley's catheter in the inside the urinary bladder. However, there is
Okay,
no reflux, vesico-ureteric reflux on either side.
okay.
So in my routine practice, I will like to take the history of the patient and also ultrasound to see the status of the prostate if it is enlarged.
What is your
Uh,
differential diagnosis other than intravesical obstruction? There are a characteristic appearance here. This is not just a trabeculation.
yeah, yeah,
What?
and this is pear-shaped bladder, and also
Okay. So why
and
why
also
it is pear-shaped? There are some contracture here. There are some dysfunction. Okay. What is the appearance? The name of this appearance?
Sir detrusor bladder inactivity.
Okay, give me another differential diagnosis other than intravesical obstruction.
Sir, it could be due to some neurogenic cause.
Excellent. In neurogenic bladder, it gives a characteristic Christmas tree appearance. And the
Yeah,
difference
Chris.
between the Christmas tree and the intravesical obstruction, look at the size at least. This is reduced size. In comparison, if there are obstruction here, the bladder must be larger, correct? Larger. But here looks like smaller and contracted from here. This is a contracture due to a neurogenic pathology, a neurogenic etiology. So this is a Christmas tree of neurogenic bladder. Thank you, doctor, so much. Dr. Miga.
Hello. Yes,
Hello?
Dr. Rami. Yes, Dr.
Come.
Rami. Yes, Dr.
Yeah,
Rami.
you didn't take a chance today. You want to take a
No.
chance?
Yes, sure. I would like to go for one.
I think this one. This one.
Okay, I'm provided with CT pelvis, CT abdomen.
Hello?
Yeah, yes, Dr. Rami, I can hear you.
Hello?
Hello, hello, hello.
Hello?
Yeah, yes, Dr. Rami, I can hear you.
Yes. 60-year-old male patient presented with hematuria.
Okay, CT abdomen, axial cuts for 60 years old male patients presented with hematuria. I would like to go through the stack of images. This is non-contrast. These are non-contrast images.
Yes.
The bilateral kidneys appears small in size with the perinephric stranding. I would like to go through the last slide. Um, in the bladder, I noticed that there is some thickening and
Lung?
thickening note, some thickening
Yes.
noted at the in the bladder region. On,
Excellent.
and however, I would like to confirm this on the contrast images. The prostate appears normal in size. So in the now I'm looking at a liver. Liver appears normal. The bilateral kidneys are normal. I would like to go to the. Uh, I would like to see the urinary bladder.
Look at the right kidney, please.
Yes, in the right kidney, I noticed that there is some area of enhancement noted in the right renal pelvis,
Enhance.
right.
This is enhanced or hypo-enhanced.
Um, I think this is showing enhancement in comparison to the.
Okay. And then what happened here? Hello? Hello? Dr. Amiga? Hello?
Images for. Hello. Hello. Yeah, now in this region, I can again, this confirms the presence of thickening, nodular thickening in the region of bladder, in the base, in the bladder base, and also at the dome of urinary bladder. I would like to see the bilateral kidneys again. Okay. So in the region of kidneys, I also noticed that there's some area of enhancement noted in the right uh, middle calyx. So it could represent transitional cell carcinoma uh, of it could represent multicentric transitional cell carcinoma of right renal pelvis as well as of urinary bladder. Okay, okay. Now I can see that there is some defect noted in the. Uh, okay, there's filling defect noted in the calyx, and it could represent. This filling defect could be. Is it papillary necrosis? Uh, I'm not able to hear you, Dr. Rami. not able to hear.
Hello?
Hello? Yeah, now I can hear. Now I can hear you. Now you're audible.
Yes. Here, what happened? This is a relatively hypo-enhancing mass here. It shows milder enhancement in comparison to the renal tissue, renal parenchyma. Okay? Here,
Okay.
the nodularity of the bladder. So this is a synchronous transitional cell carcinoma of the left kidney. It's system, the urinary bladder, and this is a very common in transitional cell carcinoma to be multicentric or synchronous.
Yes, yes. Yes.
Dr. Mega, so much thank you for all colleagues who attended today. Hopefully we will meet next week. Thank you so much.
Yeah. Thank you so much, Dr. Rani.
Thank you. Bye.